Many thanks for giving me the opportunity to discuss about pre-op chemotherapy in liver metastases. So, as you know, our policy regarding metastasis is conditioned by this graph, where you can see that surgery remained the only possibility of long-term survival for the patient. And these are true life results because it reflects a LiverMed survey which account now for more than 20,000 patients, 280 centers and 67 countries, irrespective of the expertise of the center. 42% 5-year survival, much more than patient, of course, non-resected. And because of this, clearly, when we see all the population of patients with liver metastasis, those patients with resectable disease, the minority of them, go to surgery. This is the endpoint, and non-resectable patients, the majority, go to chemotherapy. However, I would say that this has a little bit complexified in the last recent years, and now there is 3 categories of patient. The first one, it's easily resectable patient. For this type of patient, surgery is the main endpoint, plus or minus FOLFOX. We will come to that. At the other extreme, we have definitely unresectable patient because widespread liver disease or extrahepatic metastasis. And for this patient, only palliative chemotherapy will be useful. But in between, the most important group is that of marginally resectable patient, either because the number or because the size. And in this patient, optimal therapy with a very good surgery is absolutely mandatory. So if we come now to the group of resectable patients, the minority of them, the rationale, I would say, for neoadjuvant chemotherapy is only related to the fact that the cancer relapse after surgery concerns 2/3 of the patient. And so we need to improve the result after surgery. But we know that resectable patients represent different subset of patients. We have such type of patient, resectable, easy. We are not so well convinced that this patient need really chemotherapy. And we have also marginally resectable one. For those patients, possibly chemotherapy will be probably much more important. And so we have 3 types of study available to try to take our decision. One is a retrospective study that we did some years ago with a group of Yokohama in patients with more than 5 liver metastases, retrospective study. And we were surprised to see that patients with neoadjuvant chemotherapy and surgery has a much better outcome as compared to those treated only by immediate surgery. But more recently, a randomized study done on a multicentric pattern in Europe show that, in fact, FOLFOX plus surgery plus FOLFOX was associated with a better disease-free survival at 3 years, and this was very important to consider the policy for patients with resectable metastases. However, the new update of the data clearly showed that despite the improvement of PFS, there was no improvement of overall survival. And so this study was a little bit questioned about the clinical relevance. In addition, we mixed synchronous and metachronous, 1 and 4 metastases, pre- and post-operative chemotherapy, so it was difficult. And a question remained. Is perioperative chemotherapy really useful for solitary metachronous colorectal liver metastasis? And we did, in LiverMed survey, a study on it, and we came to the conclusion that although preoperative chemotherapy does not seem to benefit the outcome of patients with solitary metachronous colorectal liver metastasis, post-op chemotherapy is associated with better overall and disease-free survival, mainly when the tumor diameter exceeds 5 centimeters. So in this group of patients, there is apparently no interest of doing any neoadjuvant chemotherapy. And more recently, we tried to refine a little bit the preoperative chemotherapy by adding cetuximab, anti-EGFR therapy, combined with FOLFOX, and this was a randomized trial comparing conventional chemotherapy, FOLFOX, with chemotherapy plus cetuximab. And the results were very, very surprising. Despite the better response, as expected, in the group with cetuximab and FOLFOX, in fact, the overall survival was lower after resection of patients receiving previously cetuximab and FOLFOX as compared to those receiving only FOLFOX. And so, presently, this is a very, very confusing study. If we go a little bit in a way to say what could be the interesting point to take into consideration, if we take the number, you have here in red the survival curve of patients receiving neoadjuvant chemotherapy, and in green, those not receiving any chemotherapy. 1 metastasis, no influence. Up to 3 metastases, no big influence. More than 5 metastases, you can see here that the survival curve of those receiving chemo is a little bit higher than that not receiving chemo. And if you take the group in liver met survey, more than 3 metastases, more than 5 centimeters, at that time a significant difference appeared in favor of receiving neoadjuvant chemotherapy. So the message is clear. The more extended is the disease, even when resectable, the most useful will be the chemotherapy. Now we come to the group of non-resectable patients. Of course, for this patient, we have no choice. We should choose chemotherapy. And chemotherapy has done tremendous progress in the recent years with the first revolution with the discovery of irinotecan and oxaliplatin, the second revolution represented by the targeted therapy, coming now to the fact that the median survival for the first time in the history of colorectal metastatic cancer reached more than 2 years, of all patients confounded. However, these benefits, I would say this progress of chemotherapy, has not been translated into long-term survival benefits. When you see the patient non-operated with FOLFOX or patient non-operated with FOLFIRI, you have absolutely no possibility of long-term survival only with chemotherapy. And the targeted therapy has not changed really this type of figure. If you see here the group of patients treated with FOLFIRI and cetuximab, there is almost no chance for a patient to be alive at 5 years with only chemotherapy. And for this reason, the main objective of the strategy in these unresectable initially patients is to increase the number of patients suitable for resection. And by the past, when we were confronted to this type of patient, we decided some years ago to explore what may be the role of surgery in this initially unresectable patient, downsized by an effective chemotherapy. We come to the first results that, in fact, operating this initially non-resectable patient was associated with a 33% 5-year survival, a lower survival than those with resectable disease, but a survival much higher than patients unsubmitted to surgery. And this initial experience only, I would say, observed in our group was confirmed, and today we may see here, as you can see in liver met survey, almost 3,000 patients all over the world has been operated after being considered initially unresectable with exactly the same survival benefit at 5 years as that reported many years ago. So today, it's common and it is accepted that when a patient is downsized by a good chemotherapy, he should go to further resection. Now, the condition for achieving high resectability are 2 conditions. The first one is an optimal first-line chemotherapy. Why an optimal first-line chemotherapy? Because when you see here the globality of patients operated in liver met survey, you can see that the vast majority of them have been operated only after 1 line of chemotherapy, meaning that the higher the number of lines, the lower the chance of resection. A second important argument is this one provided by Volprecht and al., correlating the response rate with the resection rate. Whether you take unselected patient or you take liver-only patient, you can see that there is an absolute correlation between the response rate and the resection rate. And so the most effective is the chemo, the best are the chance of surgery. And we are not surprised, for example, that when you observe in liver-only patient a 70% response rate, which is today very common, finally 50% of patients may be downsized for effective resectability. And when you add to chemotherapy EGFR inhibitors, what we know today in this meta-analysis is that by adding anti-EGFR, meaning cetuximab or panitumumab, we increase by 60% the chance to resect the patient, as it appears here in this meta-analysis. And recently, a China study, randomized trial, demonstrates that by adding cetuximab to FOLFOX or FOLFIRI was associated with a significantly higher rate of resection, 3 to 4-fold the resection rate observed with CT alone was observed by adding cetuximab to chemotherapy. And the benefit in survival was plus 62% in terms of PFS and was plus 65% in overall survival as compared to the group of non-resectable patients. What is true for anti-EGFR is partly true for anti-VEGF, I mean Avastin, bevacizumab. But as you can see here, there is no clear difference in resectability rate induced by bevacizumab. And this is related to the differential effect of anti-VEGF, who, more than shrinkage, they induce a sort of pseudo-necrosis of the tumor. But to induce resectability, you need really a tumor shrinkage. And recently, at the ASCO meeting, this study was reported comparing head-to-head cetuximab and bevacizumab associated with FOLFIRI. There was no significant difference in response rate, but you can see here that there was a difference in survival rate in favor of cetuximab combined with FOLFIRI. Anyway, and this is a good publication from the MD Anderson and the Mayo group, showing that when medical oncologists are using all these new drugs, not only we increase significantly the number of patients coming to resection, not only we confirm that with liver resection the results are much better, but we increase by threefold the median survival of resected patients as compared to non-resectable one. Second condition now, the chemotherapy should be as short as possible. And you, as surgeon, you should say that to your medical oncologist. Why a short duration chemotherapy? Because a prolonged chemotherapy is not only more risky in terms of liver insufficiency, demonstrated by the MD Anderson group, but it's no more efficient in terms of duration. And you can see here that the major response and the complete response is not increased from the time you go after 8 courses of chemotherapy. In addition, in potential candidate for surgery, we know that the longer the chemo, the higher the postoperative morbidity. So we have no interest to do a prolonged chemotherapy. In addition, in terms of survival benefit, the more prolonged is the chemo, the lower the survival after liver resection. The higher the number of lines of chemotherapy, the lower the survival after liver resection. In addition, the risk of prolonged chemotherapy are of 3 types. The first one is a complete clinical response. We will come to this with Mike Chotti, which is a paradox, because when a lesion disappears, most of these lesions, while on chemo, are still active. The second pitfall of a prolonged chemotherapy is a progression after initial response. And we know today that when we operate patients while in progression on chemotherapy, the benefit and survival is much lower. And finally, what we know also is, I don't know what happened here. And what we know also is the hepatotoxic effect of chemotherapy and such type of liver, blue liver induced by oxaliplatin administration, yellow liver in relation with steatohepatitis. And finally, for definitely unresectable patients, we should be careful today because of the efficacy of chemotherapy. And such type of patients which appear initially as probably definitely unresectable, sometimes could be downsized by a good chemotherapy. And the proposal of an expert committee has been to wait 2 months of treatment before assessing definitely the resectability of liver metastases. And so, putting all this together, our effort as surgeons is to try to extend the indication. By this way, we gain, I would say, 10% more resectability. If we include now a good chemotherapy and the link between good chemotherapy and surgery, by rescue surgery, we increase still by 10% the possibility of resection. And if we add to this targeted therapy and specific technique, portal embolization, two-stage hepatectomy, we still increase the number of patients. And we come today to a sort of provocative assessment that 50% of liver-only patients, initially non-resectable, may come further to resection thanks to all these means, a good radiologist, a good surgeon, a good chemotherapy. So in conclusion, I would say for resectable patients, neoadjuvant chemotherapy, we have no evidence today of prolonged overall survival with chemo. The DFS is prolonged, but it's difficult to make the difference between the number of lesions, the timing of metastasis, and we still need more study to demonstrate a pre versus post-op chemotherapy. It is probably useful in multinodular, but probably not useful in single metachronous colorectal metastasis. And presently, there is no evidence at all of the usefulness of targeted therapy. For marginally non-resectable patients, we should stress the importance of an optimal and short-line first-line chemotherapy. Optimal mean triplets or doublets plus targeted therapy. Anti-VEGF induce more necrosis but less shrinkage. Anti-EGFR induce less necrosis but more shrinkage, and a significantly higher rate of conversion to resectability. And overall survival appear to be better with cetuximab as compared to bevacizumab in patient RAS wild type. For, finally, definitely non-resectable patient, we can try, I would say, optimal chemotherapy, at least for liver-only young patient, and to assess the response at 2 months. If we obtain a major response, sometime we may reconsider hepatic resection, coming to the concept of accidental hepatectomies. If no major response, palliative chemotherapy, but anyway, the importance of multidisciplinary team decision. Thank you for your attention.